Greetings to my beloved teachers, distinguished dignitaries on the dais and off the dais. Until now, the weather here was very hot and dry. Now it is shifting towards wet and wild with more of hurricanes and floods on the way. I would like to begin the topic by recalling last year's World Kidney Day theme, which was a call meant to us to get prepared for the unexpected, the natural disasters which disproportionately affect the most vulnerable of the patient population whom we cater to, that is our dialysis patients. On the morning of September 20th, 2017, the otherwise peaceful island of Puerto Rico was devastated when one of the most deadliest Atlantic hurricanes ever in US history had made its landfall there, destroying many houses, knocking down more than 80% of the electrical poles and mobile phone towers, resulting in the 3 million residents being homeless, out of which 6,000 were dialysis patients. There is no empirical estimate of health outcomes or migration of the dialysis patients of Puerto Rico, but the personal anecdotes report that most of these patients had either been evacuated or self-migrated to the neighboring cities like Florida and got the dialysis done there. And the fact that there is no increased evidence of mortality among the dialysis patients of Puerto Rico again suggests the fact that the disaster preparedness was well in place there, resulting in a continuity of dialysis care for the patients in spite of an extreme weather event which has occurred there. But that was not the scenario when early back in 2005, when Hurricane Katrina and its subsequent floodings had devastated the New Orleans and the coastal Mississippi. Most of the dialysis centers were shut down and the dialysis patients had to literally scramble to find the dialysis care. And there was considerable chaos and the loss of communication infrastructure added to the confusion, and many dialysis patients arrived at alternate dialysis locations, resulting without any medical information on their hands, and this resulted in suboptimal delivery of the dialysis for them. And a study conducted among the dialysis patients in the aftermath of Hurricane Katrina reported that about 44% missed at least one hemodialysis session, and about 17% missed more than 3 or more sessions of hemodialysis, resulting in enhanced hospitalizations and emergency department visits. This situation resembles the scenario in my own home state, Kerala, when in 2018, the torrential rains during monsoon season, which poured uninterrupted, resulted in an unprecedented floods. Until then, the God's own country had been witnessing only minor cyclones and minor landslides. But initially we thought this was an aberration occurring only once in a century. But in 2019 also, the floods of almost equal intensity struck the land. And now in Kerala, this has become a bi-yearly occurrence. There is a study on the impact of floods in dialysis service delivery in northern Kerala by Feroz Aziz and his team. And according to them, many dialysis centers were waterlogged, had their RM membrane disrupted, had the source water contaminated, power failure, and accessibility issues for the patients and staff. And many patients also reportedly missed their hemodialysis sessions. So whatever be the type of disaster, all these disasters have the potential to put the renal patients in jeopardy. The number and the intensity of the natural disasters has been increasing, and it has increased about 10-fold over the last 30 to 40 years. And of the 81% of the global total disasters occur in the Asia-Pacific region, and India comes in the top list of 5 countries. And according to CSE, India witnesses some form of natural disaster every day. Natural disaster is defined in relation to health as any destructive event that produces a discrepancy between the number of casualties and the treatment capacity. And this disaster nephrology is an emerging area of nephrology which deals with the problems of acute kidney injury and CKD in the aftermath of disasters. And this is an extension of the original term seismonephrology, which is a branch of nephrology which deals with the kidney health problems in the aftermath of earthquakes. The patients who require dialysis in a disaster setting, the majority are the MHD patients, but there could be CKD G5 NT patients who are yet to begin on hemodialysis, and not least to mention the spectrum of AKI which can happen during disasters. The impact of natural disasters on renal failure patients is broadly categorized as indirect, direct, and mental health effects. All the factors mentioned in the previous slides and all these logistical issues will lead to dialysis disruptions, which can translate into life-threatening events like hyperkalemia, fluid overload, and respiratory failure, resulting in enhanced mortality and hospitalizations. There is only one study which addressed the mental health problems of dialysis patients during a disaster, which reported that about 24% showed features consistent with post-traumatic stress disorder, and about 48% showed depression, because these dialysis patients have to be in separation for so long from their family members until they can return to their homeland when the parent dialysis unit starts functioning. Regarding peritoneal dialysis, it is easily maintained and functioning in a disaster, and there is a recommendation to switch over to PD program in disaster-prone areas. The experience of PD patients during Hurricane Katrina was in stark contrast to the experience of HD patients. Like they had been instead to carry their PD supplies along with the evacuation supplies, and also they were evacuated well in advance. And also there is one study on PD and disasters. In the study of the 22 patients, 2 patients developed peritonitis, one because of the usage of river water on the access site area, and because of the power failure, one had to resort to manual exchanges. And this is a publication from North India where the authors report the 2 lives being saved by performing acute PD in a natural disaster. There is a good amount of literature now available on the disaster management and preparedness for dialysis patients, and most of this literature comes from the US hurricane experiences. From Asia Pacific, the literature is quite few, and most of which comes from Japan. In Japan, there is a Japanese Association of Dialysis Physicians, in collaboration with the Japanese Association of Engineering Biotechnologists, have formed an information database which guides the patients during the disaster. And the Armenian earthquake in 1988 had turned out to be a renal disaster, because many of the patients had lost their lives due to Krebs syndrome and the AKI. And this exposed the lack of a coordinated, effective nephrological response to disasters. Hence, in 1989, ISN had founded this Renal Disaster Relief Task Force with the aim of assessing dialysis requirement in a disaster environment, and also for the deployment of dialysis personnel and materials into the disaster area. Since then, RDRTF has been very active, and this has been mobilized worldwide in the face of many disasters, including the most recent man-made disaster of Ukraine war. The severe catastrophic 2005 hurricane season alerted Americans to the need of a more effective response to mass casualty incidents, and with this, in 2006 in Washington, they formed the Kidney Community Emergency Response Coalition with representatives from dialysis personnel and from various governmental and private organizations. Since then, this KCRC in US has been playing the lead role in implementing and executing the guidelines and recommendations for disaster management for the dialysis patients. And it recommends that all the dialysis facilities should develop its own disaster plans and should rehearse on regular basis, and the patient should be taught by the staff, and the staff also should keep the medical records not as EMR alone but as offsite copies in waterproof locations. Also, the dialysis facilities should have alternate communication systems, backup generators, portable water, and affiliation agreement with other dialysis facilities, both the local and the regional level. The patients are also asked to participate in the evacuation drills, and they're all given an extra dialysis just before the evacuation. They'll be given identification badges and all the relevant medical information, including the latest prescription and the lab reports, and extra supply of potassium binding resins and loop diuretics. And this is the 3-day emergency diet plan which they are supposed to follow, and this suits the American needs. We in India have to formulate our own diet plan depending upon the local availability and the taste preferences. We should also address this issue of burnout of nephrology personnel in addition to the patient safety during natural disasters. We have seen how our nephrology colleagues and the staff had burned out during the COVID pandemic due to increased workload, understaffing, specific conditions, the personal and family issues, and psychological and somatic health problems. India is expected to face more and more natural disasters in the subsequent years. And our dialysis population is also growing at a faster rate. All of us are adding elderly and very elderly patients into our maintenance hemodialysis programs, adding to the vulnerability of this population. And my search for Indian literature on disaster management for dialysis patients ended in only one publication, that is by Dr. V.N. Unni from Aster Medicity Kochi, and how effectively they managed the dialysis unit during the floods. So the natural disasters could be unpredictably unpredictable. And we, as a nephrology community in India, it's high time that we innovate policies and tools to meet the challenges when the regions face natural disasters. This topic calls for research and policy implications. We have to plan ahead, rehearse, critique, and reuse a plan. And the plan should address 4 phases of emergency management: prevention, preparation, response, and recovery. Thank you for the opportunity, and thank you for the patient listening.
Thank you very much, Manjula.